Good afternoon, everyone, and thank you for joining this Endo-ERN webinar, Klinefelter syndrome from genomics to the clinic, presented by Professor Gravholt. This webinar was organized by the Endo-ERN main thematic group 7, and this particular group focuses on sex development and maturation. I'm Amy Casey, the communication manager for Endo-ERN, and you're very welcome this afternoon. Endo-ERN is the European reference network for rare endocrine conditions, and we have over 100 expert centers across Europe that specialize in rare disease, and they offer virtual consultations, participate in educational activities like this webinar. Our members also contribute to research and guideline development. We're lucky to have European patient representatives that are an integral part of our work. And last but not least, we have a registry, the European Registries for Rare Endocrine Conditions, that is one of our work packages. Before we get started, I just wanted to go over a few bits of housekeeping. We're very fortunate that Professor Gravholt will take questions, but he will do that at the end of the presentation. So feel free to type them into the question box, or you can wait until the end and I will unmute you and you can ask directly. It's my pleasure to introduce Professor Gravholt. He's a professor at the Department of Endocrinology and the Department of Molecular Medicine at Aarhus University Hospital and Aarhus University. Since 2016, he's the coordinator of clinical and research activities of the DSD Reference Center at the Aarhus University Hospital. This center is dedicated to multidisciplinary care and research in the field of variant sex development. Professor Gravholt's main research focuses on morbidity, mortality, genomics, and socioeconomic aspects of rare DSD conditions. He supervised 20 finished and 6 ongoing PhD students and has co-authored more than 250 original papers. In addition, Professor Gravholt is a past member of the clinical committee of the European Society of Endocrinology, and he's involved with several patient organizations such as the Turner Syndrome Association, the Klinefelter Syndrome Association, and the CAH Association of Denmark. Professor Gravholt is a very in-demand expert and speaker, and we're privileged to have him here today. Without further delay, I hand it over to you, Professor.
Thank you very much, and thank you for attending this webinar on Klinefelter syndrome from genomics to the clinic. And I will start out with talking about the genomics of Klinefelter syndrome. And this is a cartoon that we put together in 2018, trying to depict the genetics and the genotype-phenotype relations in Klinefelter syndrome. And here you can see that we are focusing on the extra X chromosome that is present in Klinefelter syndrome, and that we know now that the epigenetics or the epigenomics of Klinefelter syndrome is changed, and so is the global RNA expression, as is the protein expression in Klinefelter syndrome. But how this relates to the phenotype, we still don't know. And I've listed some of the characteristics of the phenotype here, and I will get back to them in a minute. But this is kind of the framework that we work in, trying to decipher the genomics, the genetics of Klinefelter syndrome, and understanding all the phenotypic traits that we see in Klinefelter syndrome. Some of the thinking also includes Turner syndrome. And as you know, Turner syndrome is a condition with 45X. And Klinefelter and Turner syndrome are human sex chromosome aneuploidies. And these syndromes actually present with a range of phenotypic characteristics that are similar, but also some syndrome-specific characteristics. And then we have this dichotomy with one extra X in Klinefelter and one X lacking in Turner syndrome. And therefore, we have been studying these two conditions together with normal females and males in order to decipher the genomics of these syndromes. And one of the things that are one of the areas that we have been interested in are the pseudo-autosomal regions PAR1 and PAR2 at the tip of the X and the Y chromosomes, these genes do not undergo the normal X inactivation we see in females and that we also see in Klinefelter syndrome. And so in Klinefelter syndrome, these PAR1 and these PAR2 genes will be expressed in triplicate, 2 from the X and 1 from the Y chromosome. But there are also several homologous genes that are not present in the pseudoautosomal regions that are also expressed in triplicate in Klinefelter syndrome. So all these genes are of special interest and perhaps relevant to the phenotype of the syndrome, but also relevant in Turner syndrome, where they're only present in one copy. And one of the things that we have been looking at is why is males with Klinefelter syndrome, why are they infertile and why do they develop hypogonadism? And previous studies from different groups have shown that the testicular blood flow in Klinefelter syndrome seems to be changed. And there also seems to be an increased testicular testosterone production in the testes, but that this testosterone does not leave the testes, and this may be due to altered testicular vascularization. So we thought that maybe the microvasculature of the testes might be distorted. And in order to look further into this, we accessed recently publicly available data from single cell studies where people have done single cell RNA sequencing, and we looked at the gene expression of individual testicular cells. And there is a lot of tissue heterogeneity, and that allowed us to identify subpopulations of different testicular cells. We also used cell chat to examine cell-to-cell communication patterns between different types of cells in the testes. And as you can see here, we were able to get some controls and some Klinefelters, but also other patients with non-obstructive azoospermia. And looking into these data, we could identify the different cell types of the normal testes, as well as the testes of Klinefelters and other patients with obstructive azoospermia. And as also found in previous papers, we could see that there were little to no spermatogenic cells in Klinefelter syndrome. And we could also see that there were more Leydig cells and less Sertoli cells in Klinefelter syndrome and other types of non-obstructive azoospermia. We then looked further into the vascular cell types that we found, and we could see that there seemed to be a distorted communication in Klinefelter syndrome between these endothelial subtypes, and that could perhaps be indicative of impaired or dysfunctional vasculature. And we could also see that when we looked at the expression of different genes, that the expression profile in capillary endothelial cells was related to angiogenesis and to the testis blood barrier tightness, and that there were downregulation of important tight junction genes that were associated with the normal testis blood barrier. You can also see that there was some angiogenetic genes that were upregulated, and these were associated with immature tip cells, inflammation, and vascular permeability, while on the other hand, cells that normally lead to a mature vasculature were downregulated, and these downregulated angiogenesis terms were associated with vessel maturation and barrier function. And then we could also see that there seems to be a strong lymphocyte activation in Klinefelter syndrome, and that this increased lymphocyte signaling seemed to be present through pro-inflammatory pathways. And there seemed to be an increased communication between the endothelial cells and lymphocytes in Klinefelter syndrome. And all this led us to speculate that the suggested increase in neoangiogenesis, or at least the first part of neoangiogenesis with clip cell formation, perhaps leads to vascular permeability, as illustrated in this cartoon, where this illustrates the normal formation of blood cell of the vasculature in normal males, while there seems to be an increased blood cell or vasculature formation in Klinefelter syndrome, but that this is immature and that it never really matures. This, if this is so, this might be this may explain the lack of normal vasculature in Klinefelter syndrome, and could also explain why the apparent increased production of testosterone by Leydig cells is not leaving the testes, but staying in the testes. This is a work in progress, and we have just submitted these data for publication.
Professor Gravholt?
Yes?
I'm terribly sorry to interrupt you, but the audio is slightly unstable. If I could ask you to get a little bit closer to the microphone, that would be very helpful.
Closer to the microphone. I hope this becomes better.
That is much better. Thank you.
So we recently also published this new study where we studied 3 different tissues in Klinefelters and in Turner syndrome, and in male and female controls. And here we studied, as you can see, both blood, fat, and muscle in these different conditions, and studied these samples in the same individuals. And when we look at X-chromosomally expressed genes, we could see that a lot of the suspects that I told you about initially, some of the escape genes from either the PAR region or from other parts of the X chromosomes, were actually differentially expressed across all these 3 different tissues, and in both Klinefelter and Turner syndrome, compared with females and males. And some of these will be, of course, be familiar to you. For example, the exist gene, which is the gene that regulates X chromosome inactivation, but some of them will clearly be new to you as they were to us when we saw them. I have framed one of them, which I'll get back to a little bit later. We then also looked at autosomally expressed genes, and you can see that across the remaining autosomes, some of them were also differentially expressed in blood, muscle, and fat. But you can see that it was not the same genes that necessarily were differentially expressed in the different tissues. We then also went on to look at the DNA methylation, and here I know this is quite confusing, but here we also studied X chromosome methylation in both blood, fat, and muscle, but also in the autosomes in the same tissues. And as you may appreciate here, you can see that also the DNA methylation pattern is really different in these different tissues, with and not the same in blood compared with fat, and compared again then with muscle, just leaving us with a very complex pattern of also DNA methylation. And in another recent study, we studied this gene that I alluded to before, SLC25A6, and this gene had previously been linked to QT interval, and in this study we could see that the ECG changes with QT interval changes that had previously been observed in Klinefelters and in Turners, compared with normal females and normal males, was actually closely linked to the expression of this pseudo-autosomal gene. And we could actually demonstrate an inverse relationship between the SLC25A6 dosage and then the QTC interval, indicating that SLC25A6 contributes to QT interval variation, which had previously been presented in Turner syndrome and in Klinefelter syndrome. So maybe this gene is also part of the story of the genotype-phenotype relations in Klinefelter syndrome. So the perspective in these new data is that we, of course, know that there is an altered sex chromosome count in Klinefelter syndrome. We knew beforehand that there were changes in the transcriptome, also in the methylome, and also, and I haven't shown you this, but also in the circular transcriptome. We now can say that this is present not only in blood, but also in fat and muscle. What we don't know is that how these changes that seems to be pervasive or global in the genome of Klinefelter syndrome, how do they relate to the phenotype, and what are the changes in other types of, for example, non-coding RNAs and the histone and chromatin modifications and so on, and are there changes in other relevant tissue, as for example the brain or in other relevant tissues? We yet don't know. So what I'm showing you is a very complex pattern or picture of the genomics in Klinefelter syndrome, and that there seems to be tissue-specific changes. We think that this is very intriguing, and we think that we may be closer to understanding what we see clinically when we study Klinefelter syndrome. And then I'll move on, shift gears, so to speak, and talk about epidemiology. And here I will start out with showing you what we have used to study the epidemiology of Klinefelter syndrome in Denmark. As you know, Denmark is a small country with only about 6 million people, but we have some very good registries, and I have listed them here, some of them, and these are the registries that we have used to study the epidemiology of Klinefelter syndrome. And as you may know, there are also now registries in Sweden and in Great Britain that can also teach us about the epidemiology of Klinefelter syndrome. One of the first questions we asked ourselves is at what age Klinefelter syndrome patients are actually diagnosed. And here is a cartoon that we made some years ago, but we have updated the numbers, and we can see that this cartoon still fits. As you can appreciate here, some are diagnosed at birth. Very few are actually diagnosed during childhood, but then we see a peak around the age of 20 to 40 years, and then a falling rate of diagnosis as patients get older. But just to emphasize, I've just seen a newly diagnosed 80-year-old male with Klinefelter in my outpatient clinic. So the average age, or the median age of diagnosis, is actually quite late. And we can also see from the Danish data, but also from the Swedish and from the data from the UK, that not all Klinefelters are receiving a diagnosis. Actually, we can see that only about a quarter of all expected Klinefelters are ever diagnosed. So a lot do not receive a diagnosis. And the age at diagnosis is in Denmark at least 27 years. And as I alluded to before, there is a very, very significant non-diagnosis. Here we have looked at the expected frequency of Klinefelter syndrome, the expected frequency derived from large population-based studies in the 80s, where it was established that about 150 males per every 100,000 males should suffer from Klinefelter syndrome. And as you can see here, we simply do not diagnose a lot of these males. So a lot of males will not receive a diagnosis. Then you can ask yourself, what actually leads to diagnosis? Well, it depends on the age of the patient, so to speak. Early on in life, it may be a cryptorchidism. Later on in childhood, delayed speech, learning difficulties during adolescence, small testes. Later on, infertility, and then decreased testosterone levels during adulthood and late adolescence, gynecomastia, development of the metabolic syndrome, type 2 diabetes, and osteopenia and osteoporosis later on in life. So what we can see from our data in Denmark is that the main driver for diagnosis is in the 20 to 40 year age range, actually infertility. Is there something that is characteristic about the anthropometry of Klinefelter syndrome? Well, we know that Klinefelters are slightly higher than the average male, but this is not, as you can see here, something that would lead to the diagnosis in a lot of cases. When you look at the remaining anthropometry, it's actually quite similar to normal males, except, of course, for the testicular volume, which is much, much lower than among normal males. But although many are having their testicular volume assessed, a lot of males are not having it assessed, and therefore many are not diagnosed appropriately. So again, we would expect about 85 to 250 per 100,000 males, but we only diagnose about 25, maybe up to 40% of the expected number of Klinefelter males. And only 10% of these are diagnosed during childhood or the adolescent years. And that leaves the median age at diagnosis at around 27 years. So we could say that we know that we should have about 4,200 in Denmark with Klinefelter syndrome, but we know that we have only diagnosed about 1,200. And we know that there should be around 345,000 in the EU, but the vast majority will not be diagnosed. We still lack epidemiological studies from other parts of the world, but important to say is that we are not doing a very good job at diagnosing our patients. So the way I think we can say we try to diagnose Klinefelter today does not work. Many are late diagnosed, some are never diagnosed, and I think that we should think about screening the entire population, or at least a part of the population, in order to diagnose more. You could ask yourself whether the surveillance by GPs and school nurses could be improved. I don't think it can, because we have tried to do that for many years without success. And I think the only way that we can make sure that patients are really diagnosed is by using the heel prick test on newborns, which could easily be used to diagnose Klinefelter syndrome. So this is something that we propose today to use as a diagnostic tool, but it has not been used any place until now. So we know a lot about Klinefelter syndrome, of course. We know about the height, the facial hair, the gynecomastia, decreased muscle mass, pubic hair. We know that there are learning problems, psychiatric disturbances, increased frequency of autism, and sometimes some mitral valve prolapse and ischemic heart disease. Type 2 diabetes, metabolic syndrome is frequent. Autoimmune diseases are also frequent. And as I showed you before, infertility and hypogonadism is also frequent. So there, you could say there is a well-characterized clinical phenotype, but as I started out by saying, the underlying mechanisms responsible for this phenotype is not elucidated. And we only know for sure to date one gene that is responsible for the increased height, which is the SHOX gene, which in Turner syndrome is responsible for the decreased height in Turner syndrome. And concerning the hormonal imbalance with hypogonadotropic hypogonadism, we think that this is linked to some of the increased risk of comorbidities like obesity, diabetes, and heart disease. And one hypothesis also suggests that other phenotypic traits seen in Klinefelter syndrome may be explained by overexpression of other non-inactivated genes, escape genes on the X, as I showed you in the beginning. Concerning the psychiatric disorders, we know from a lot of studies over the years that there seems to be an increased frequency of autism spectrum disorders, as well as ADHD, as well as anxiety, but also depression and perhaps also psychosis. We also know about the neurocognitive problems that we see in Klinefelter syndrome that in many have delayed speech development, many have verbal deficits, dyslexia is frequent, and these can emerge early in childhood and persist into adolescence and adulthood. And both receptive and expressive language seems to be affected. Whether this also relates to, is present in patients that are not diagnosed until now, we of course cannot say. When it comes to executive function, there are relatively fewer studies, but the ones that are suggest that there is that the working memory and in attention and inhibition and cognitive flexibility is decreased in Klinefelter syndrome. And the studies also suggest that the potential linguistic capabilities is linked to changes in the brain. And different MRI studies have been presented, and researchers have tried to link these to the cognitive phenotype or the personality profile and psychiatric comorbidity, but up until now without a lot of luck, because there doesn't seem to be a clear connection between the changes that we see in the brain, in the different nuclei, as you can see here, where a lot of different nuclei are either smaller or larger in Klinefelter syndrome, but it has been difficult to link these persuasively to cognitive or personality traits. When it comes to IQ, there seems to be a discrepancy between the verbal IQ, which is normally always somewhat reduced, but that does not go for the performance IQ, as you can see here. But when you look at the different studies that have studied IQ, it seems to be diminished compared to the normal 100 to 110, at least in most studies. There are different studies that have looked at how many Klinefelter males or boys receive special help in school. And as you can see, we have presented them all here, and at least up to 50% of boys with Klinefelter syndrome receive special help in primary school. Either they have been diagnosed beforehand, or they're diagnosed after they went out of they stopped their studies. Now, this is a study we did some years ago where we administered a number of questionnaires to patients with Klinefelter syndrome. And as you can appreciate here, for every trait that we studied, that be physical health, psychological health, social relationships, or the SF-36, you can see that Klinefelters rate their general health lower than controls. We also studied psychological strain during different phases of life, and conclusively, we could say that every phase that a Klinefelter child or adult went through, there seemed to be more strain than compared with normal male controls. Then I'll turn to talk about the mortality, morbidity, and how testosterone replacement therapy may be of benefit to males with Klinefelter syndrome. This is a study from the UK, just telling us that mortality from all causes in the UK is increased compared with a normal population. And this was due to a lot of different conditions, as you can also appreciate here. So a number of different conditions that are not necessarily linked lead to this increase in mortality. And looking at Danish studies, also we can see that mortality is increased with a hazard ratio of about 1.9, and that corresponds to a median loss in lifespan of about 5.6 years. We can also see that when we look at the hazard ratio before the age of 30 or the age of 15, see that it was much higher, meaning that young individuals with Klinefelter syndrome have a much increased mortality risk. Again, you can see that there are a lot of different or conditions that can lead to this excess mortality that we see in Klinefelter syndrome. One of the obvious problems is that osteoporosis is more frequent in Klinefelter syndrome and likely the result of hypergonadism. So that would be easily treated when we treat with testosterone treatment. But this is a study we did some years ago where we used high-resolution PQ-CT to study the bone or architecture, and we could see here that there was a reduced trabecular density at the tibia, which was similar to what we see in postmenopausal women, and unfortunately we could not study the effect of testosterone replacement therapy on bone microarchitecture, but that would be interesting to do in the future. Cardiovascular disease is also a problem in Klinefelter syndrome, especially venous thromboembolism, and here are some evidence from different cohort studies from both the UK, Sweden, and Denmark, and they unanimously show that the relative risk for venous thromboembolism is 5 to 8-fold increased. And that is considerable, and that means that at the age of 70 years, 1 in every 5 males with Klinefelter syndrome will have had a venous thromboembolism experience. We, in a recent study, looked at the use of medication among Klinefelter syndrome males and compared that with a control group. And as you can appreciate here, you can see that drugs like anticoagulation drugs, platelet inhibitors, statins, antihypertensive, and antidiabetics is used much more frequently among Klinefelters, and that go along with an increased risk of comorbidity from conditions where you would use such drugs as hypertension and diabetes, hypercholesterolemia, and arteriosclerosis, which was also quite increased among Klinefelter syndrome males. We also looked at how testosterone treatment might affect the risk of venous thromboembolism. And first of all, we could see that also in Danes with Klinefelter syndrome, there is an increased risk of thromboembolism, and we could illustrate that with this Kaplan-Meier plot, just showing you that it was much increased compared with control males. But in this study, we could also see that the untreated Klinefelters actually had a higher risk, almost significantly higher than among the treated Klinefelters, suggesting that testosterone treatment may actually protect you from thromboembolism, at least when you have Klinefelter syndrome. So what types of testosterone treatment do we use? Well, we use libido injections, which is of course a depot type of testosterone. And then we use different gels, either Testosterone or Testovan, and they, of course, have to be applied every day. And we wondered whether there might be advantages or differences between these different modes of administration of the drug. So in this study, we looked at all the patients in the outpatient clinic that had received treatment for at least 5 years. And as you can see, they are in their 40s on average. They had a diagnosis of Klinefelter syndrome in their 20s, and they were similar of weight and height and BMI, so to speak. And most of them started treatment with PRT early on, between 18 to 49 years, but also some later on in life. And here you can see some of the results. You can see that the testosterone level amongst the ones that received injection versus the one that received a gel was actually similar, but that FSH and LH was higher in the gel-treated group. We also looked at metabolic outcomes, and we could not see any difference in the levels of cholesterol, but also not in levels of HbA1c or other markers of metabolism. We also looked at the testosterone level over the years, and you can see that whether you receive transdermal or injection therapy, it seems to be quite similar. But as mentioned before, the LH level and the FSH level was higher during transdermal therapy. We think it has to do with the pharmacodynamics of the gel treatment. But the level of hemoglobin, a marker of androgen exposure, was similar in the two groups. On the other hand, we can also see that the BMI of our patients, at least in our outpatient clinic, is high, and it also increases with age. And that is something that we have to take care of and be cautious about, because it tells us that many of our Klinefelters will actually become quite obese with age. We did an RCT, a small RCT some years ago of testosterone use in Klinefelter syndrome. We compared placebo with testosterone over half a year. And you can see here that during treatment, there was a reduction in the total abdominal fat and the intra-abdominal fat, which is supposedly the most dangerous part of our fat compartments. We can also see that the hemoglobin increased as it should, and that insulin-like growth factor 1 also increased during treatment. So the expected effects of testosterone therapy is also present in Klinefelter syndrome. Somewhat to our surprise, we could see from our epidemiological studies that only about half of all patients with Klinefelter syndrome do actually receive appropriate testosterone treatment in Denmark. And we looked at our own data from our own outpatient clinic, where we have about 350 Klinefelters, and almost all of them are treated. We talked to our colleagues in Copenhagen. They could also tell us that all their patients were being treated. So we concluded that the remainder of the population of Klinefelters in Denmark are seen by general practitioners or in other outpatient clinics, and they must be the ones that are not treated. We don't think that this is appropriate, and we could see from the data we could extract from the registries that they actually were eligible for testosterone treatment. So what can we say about testosterone and effects on different parts of the phenotype in Klinefelter syndrome? Well, here I have listed some of the traits that we see in Klinefelter syndrome, and also whether it may be beneficial to treat with testosterone therapy. Of course, it will increase beard growth. We also think that it will reduce the risk of developing the metabolic syndrome and type 2 diabetes, and as shown before, it will decrease abdominal adiposity and the increased body fat. It will also have an effect on the risk of osteopenia and osteoporosis, and of course also on the decreased muscle mass and strength, which is present in Klinefelter syndrome. We also think that it may reduce the risk of venous thromboembolism, but we acknowledge that further data are necessary to prove this point. And maybe it will also reduce the risk of ischemic heart disease and, of course, the development of gynecomastia. Whether it will have any impact on the learning disabilities and the psychiatric disturbances that we see in Klinefelter syndrome has yet to be determined. But we think that it may at least improve some of the neurocognitive issues that we see in Klinefelter syndrome. We've also studied the socioeconomic status of Klinefelter syndrome, just confirming previous studies showing that there is an effect on, or Klinefelters are often retired early on in life, and that the annual income throughout the lifespan is much lower than among other males. And we can also see that more Klinefelters actually do live alone compared with the background population. So testosterone treatment, we think, is vital and important in Klinefelter syndrome. It, of course, increases testosterone, hemoglobin, and IGF-1 in the blood circulation. It reduces fat mass and the risk of developing gynecomastia. It increases muscle mass, and it may reduce the risk of venous thromboembolism and may reduce the risk of depression. It may also improve well-being, and it may decrease the risk of diabetes. And therefore, we think that every Klinefelter male should be at least told about these positive effects of testosterone treatment. So what can we do more for our patients with Klinefelter syndrome? Well, we think that scholastic interventions during the childhood and adolescent years is necessary in many cases. Psychological treatment, especially with focus on neurocognitive abilities, and we think that this may be something that the endocrinologist may be able to pick up in the outpatient clinic. We think that information about the syndrome to patients, parents, family, and friends, and other professional authorities is very important. And we also think that fertility preservation, which I have not talked a lot about here, is something that more and more becomes pertinent to the treatment of Klinefelter syndrome males. And then, of course, prevention of the associated morbidity, of which I've shown you some, but not all here. The risk of or the associated morbidity burden is very large in Klinefelter syndrome, and we think that we can reduce this, or at least prevent some of this associated morbidity. And we also think that care should be anchored in the endocrine department, and that the endocrinologist should act as the anchor physician, so to speak. So what we do is that we transfer our adolescent patients from the pediatric clinic to the adult clinic, and that we have relations to other relevant departments. And for us, we also run research projects with several departments. And we partner with a lot of different departments in this aspect. Of course, fertility, but also odontology. There are many problems with teeth in a lot of patients. Plastic surgery, they take care of gynecomastia. The Department of Neurology, I didn't talk a lot about Parkinsonian-like symptoms, but some patients have this, and this seems to be become more predominant with age. Cognitive psychologists for neurocognitive therapy, and then we also do research with the Department of, or the Center for Functionally Integrated Neuroscience, and we partner with the Department of Linguistics as well for research purposes. And then the Department of Cardiology and Urology and Orthopedics and others where need may be. So as said before, I think the role of the adult endocrinologist should be one of being the anchor physician to establish collaborative agreements around the patient with Klinefelter syndrome, and of course spread knowledge. And we actually also stage information days where we invite both patients and their relatives to come and hear more about Klinefelter syndrome. And of course, then consider research, because there are so many things that we still don't know about the syndrome. So how do you monitor your patient in the outpatient clinic? Well, there is no real consensus on this, and therefore I think we need international guidelines that are agreed upon about by a number of different organizations and bodies that take care of Klinefelter syndrome. We monitor using LH, FSH, hematocrit, hemoglobin, testosterone. We use a DEXA scan to monitor changes in body composition. We also use PSA, at least when the patient is above 50 years in age, but we do not have any suggestion that prostate cancer occurs with increased frequency. Then we also monitor the general well-being, increase in muscle strength, and increase in quality of life, and we focus on neurocognitive abilities. So with that, I will thank you for listening, and then just show some of the people that have been involved in the research that we are performing, and then thank the funders of our research. And with that, I will take the questions and discuss. Thank you.
Thank you very much, Professor. It was really quite a comprehensive presentation, taking us through all aspects and the ramifications of the low diagnosis rate. While people gather their thoughts and prepare their questions, I wonder if you might entertain a question from me, a layperson. You mentioned earlier about the heel prick at birth. Is that something that is happening now, or is that your recommendation? What is actually happening in Denmark?
That's something that we're trying to establish in Denmark. We haven't done that yet, but we're engaging in discussions on the subject. And we think that that might be a way of diagnosing more patients early on in life, and also then perhaps prevent or at least intervene and help Klinefelters go through the school years. We know from adults that many have been bullied during their school years because they perhaps not were doing so well, and that has been a tremendous burden for many patients. So we think that we may be able to avoid this by diagnosing patients earlier and then intervene with scholastic interventions, help in different ways, help in learning to read, learning to do math, and so on and so on.
Okay, so it's about getting ahead of everything with the actual diagnosis. Thank you. We have some questions and some hands raised now. Professor Grassman, I've unmuted you there if you'd like to unmute yourself.
Yes, hello. My name is Corinna Grassman. I'm a pediatric endocrinologist from Germany. So the idea to identify these patients by the newborn screening is very appealing, but the question is, what do you anticipate is the phenotype of the 60% of individuals with Klinefelter syndrome who we don't know? Can you guess on that? Because I mean, patients will ask, what is the benefit if I know I have an extra X, if there are no medical conditions that need to be treated? My guess would be that there are many undiagnosed, apparently there are many undiagnosed boys in school who likely struggle. But does that really pertain to most of them?
Well, as you can probably guess, I cannot say for sure, but the last couple of years we've actually seen some new data coming out that can maybe indirectly answer this question. The UK Biobank has been used, and there they have actually seen that a lot of Klinefelters participated in the UK Biobank study of about 1 million Britons, and several were actually Klinefelters, but they were undiagnosed. When they looked at these undiagnosed Klinefelters and compared them to other Klinefelters, they could see that they actually show exactly, not exactly perhaps, but they have the same phenotypic traits as other diagnosed Klinefelters, indicating that maybe the undiagnosed proportion of Klinefelters is actually similar, or at least close to similar, to the diagnosed population. Of course, there is a phenotypic variability. There is with any condition, but I think that a lot of patients will actually be quite similar. And one more thing that underlines that is that when we see adults that are diagnosed, for example, at the age of 40, I always ask them, so how was your early life, your schooling years and so on? And they almost invariably tell me that it was not very good and they did not learn a lot, and they only learned to, for example, read when they became adults and so on. But again, there is phenotypic variability. Some are actually very good in school, and there is also variation there. But almost all, if not all, the patients that I've seen during adulthood have actually traits that could have been picked up earlier on in life. So I think in general, we will improve the lives of a lot of patients if we diagnose patients earlier. But I acknowledge that I do not have sound proof for this, so I think it will be good to run a period of do this as a study for some years and then gather experience.
Thank you.
We have another question in the question box. How to address fertility concerns?
I can tell you what we do, and there is not a general agreement on this, but when we see a young Klinefelter, we usually start testosterone treatment if it's deemed necessary, and then if there later on appears a fertility wish, let's say the patient shows up at 18 years and he as 25 or 30-year-old, he has a fertility wish. We then stop the treatment for half a year and refer to our fertility specialists that do TC normally to see if there are any viable sperm in the testes. So that's our way of going about this. But there is not a general consensus, something that you should start out by doing TC early on in life and then see if there are any sperm in the testes. So we still need more knowledge in this area before we can say what is the most optimal way of going about this.
Thank you. Another question asks, is Klinefelters preventable with any measures?
I would say the answer today is no, because we don't know what causes Klinefelter syndrome. We know that it is either in the maternal or in the paternal line that there is non-division of the sex chromosomes, and therefore Klinefelter can occur. But as long as we know why, as long as we don't know why this is happening, I don't think we can prevent Klinefelter syndrome. But of course, you can diagnose Klinefelter syndrome during pregnancy, and many times we can see that this leads to the pregnant woman and coming father to choose to opt for abortion in some cases, but in other cases they choose to continue the pregnancy. But we cannot say what causes it, and therefore we cannot prevent it.
Thank you. How common is gender dysmorphia in Klinefelters, and is there any difference between treated or untreated?
Answering the last question first, we don't know if there's any difference whether or not you are treated with testosterone. And then coming back to how common it is, it's uncommon, but it's not completely non-occurring. I think I have a couple of males that have some sort of gender dysphoria, and that's what I hear from other clinics around the world as well, that they typically have some patients, and there are also a few smaller reports on patients with Klinefelter syndrome and gender dysphoria. But I don't think it's a common problem. We asked, in a questionnaire study, we asked about these issues, and it was quite uncommon. About 1% of the respondees reported that they had gender dysphoria. But we lack, I think, better data.
Okay, we're coming towards the end of our time. If you have a burning question that you would like answered, please put it in the chat or raise your hand. I have another question here for you, Professor. Is there any evidence that it might be more likely that sperm will be obtained closer to post-puberty rather than later on in life?
Not with the data that we have right now. So the studies that are out there have not been able to pinpoint age as a determinant of the success rate after TC. So although it seems perhaps intuitively clear that it should be so, that the younger you are, the more likely you are to have sperm, this has not been shown conclusively. And that's why we're not so reluctant to perform TC later in life. Actually, we perform TC up to the age of around 40, and we have found sperm in some of these patients as well. The reason why there is sperm is a very good question, and we simply don't understand that. That the sperm seems always to be normal, and that is surprising. And that kind of suggests that there may be pockets of mosaicism with a normal 46XY complement in certain areas. That has not really been shown conclusively.
Okay, thank you. I think that this, as I said, this has been very informative, and it was a lot of information. I think that maybe questions will come later, and perhaps you'll come back and give us a little taster in later next year. But for now, I would like to thank you so very much for your presentation. And for those of you in the audience, I would like to let you know that our next webinar is in October, and it focuses on the non-classic CAH, undiagnosed condition. And I would encourage you to sign up for the Endo-ERN newsletter on our website if you haven't already, to be kept up to date. Thank you all for your time and attention today. In particular, thanks to you, Professor Gravholt. It was very informative. Good day to you all.